Good afternoon, everyone. I'm Dr. Sindu Pillai, the president of AKMG, and welcome to AKMG Women's Forum Seminar. Happy International Women's Day to everyone, to one and all. Welcome our keynote speaker, Dr. Sonora Jha, and all our speakers and moderators. As we all know, International Women's Day is celebrated on 8th of March of every year around the world. It's the day dedicated to celebrating women's achievements in various social, cultural, and political fields. Its roots can be tracked all the way back to early 1900s. Women have taken on multiple roles to adapt to the changes in the society we live. While continuing to meet family and household responsibilities, we take care of our professional and personal interest, efficiently keeping the work-life balance. As we continue to celebrate our strength and resilience of women around the world, let us continue to uplift, empower, and support each other. Let's continue to inspire others and be inspired by others. Follow our passion and let the success of every woman be an inspiration to one another. And let's make a difference in others' lives and a change in the whole world. I do have to remind you all, this year in 2024, the theme of International Women's Day is Invest in Women, Accelerate Progress. It emphasizes on the critical role of investing in women's education, economic empowerment, healthcare, and the development of leadership to accelerate progress towards gender equality. Let's all work together to create a world that is diverse, equitable, and inclusive. On this International Women's Day celebration occasion by Association of Kerala Medical Graduates, I would also like to honor the first Indian female doctor of Western medicine, Dr. Anandi Bai Joshi, also called as Dr. Anandi Gopal Joshi, who graduated from Women's Medical College, Pennsylvania in Philadelphia, which was the second women's medical program in the world. She was the first Indian woman to receive education abroad and to obtain a medical degree. I'm very happy to celebrate Women's Day with all of you. And we have a very highly talented and efficient AKMG Women's Forum, which we are all very proud of. Excellent program ahead of you. I would like to welcome our keynote speaker, Dr. Sonora Jha, other speakers, Dr. Oormila Kovilam, Mrs. Shubha Anand, and Dr. Manju Dawkins, and our moderators, Dr. Sheeja Pullarkat and Mrs. Kamar Amanullah. I just want to give just a briefing on our convention. Our 45th convention is going to be held at Hilton Bayfront in San Diego, August 29th, 30th, and 31st of 2024. Registration is going on very actively. And thank you all who have already registered. We will have an excellent Women's Forum session at the convention, and we are all preparing, and the preparation is underway right now. So I would like you to attend that excellent forum along with so many other activities we're going to be having. Now it's time to start our session. It is my great honor and pleasure to introduce your two moderators, and thank you so much for agreeing to moderate our sessions today. First, Dr. Sheeja Pullarkat. She is a medical graduate of Calicut Medical College, Kerala. She completed her residency and subspecialty training in hematopathology at the University of Southern California, Los Angeles. She has been the professor of hematopathology and program director of the Hematopathology Fellowship Program at UCLA for nearly 2 decades. As a faculty member at UCLA, she has won multiple teaching awards from the residents and trainees in the program. She is also the department wellness officer. In her clinical career, Dr. Pullarkat received the American Association of Cancer Research and the American Society for Clinical Oncology Awards for her work on GI cancers. In addition to her clinical duties, Dr. Pullarkat is engaged in translational research in hematologic malignancies, including acute leukemias, myeloid neoplasms, and rare hematologic malignancies. She has authored numerous manuscripts and book chapters and serves as a reviewer for various peer-reviewed journals. Welcome, Dr. Pullarkat, and thank you for being the moderator today. Our next moderator is Mrs. Kamar Amanullah. Her expertise lies in financial operations, strategic development and analysis, and human resource leadership. She was a Chief Finance and Human Resource Officer at Sisters of Mercy Regional Community of Detroit for 25 years. She was the Administrator and Director of Retirement Plans at Trinity Health Systems for 10 years, Senior Consultant to President of Beaumont Health Foundation for 8 years, and she has many affiliations and responsibilities outside of the main employment. She loves reading, playing golf, hiking, practicing and teaching yoga, and traveling. She took care of our non-CME activities at our last AKMG convention 2023 in Grand Rapids, Michigan. And Kamar's advice to women today, as we celebrate our International Women's Day, is for the both young and old generations, keep learning, invest your time in what interests you, set your own goals in life, and help and motivate other women. With that, we're going to be starting our first session. Over to you, Dr. Sheeja Pullarkat, for our first session with our keynote speaker, Dr. Sonora Jha. Thank you so much.
Thank you so much. Thank you, Dr. Pillai. Thank you. Thank you, everyone, for joining us on this wonderful day. And it is my distinct pleasure and I'm honored to present today's keynote speaker, Dr. Sonora Jha, a researcher, essayist, a writer, and professor of journalism and communication, as well as the Associate Dean at Seattle University. Dr. Jha's essays and op-eds have been published in numerous prestigious media, including the New York Times and the Seattle Times. She grew up in Mumbai and was the chief of the Metropolitan Bureau of the Times of India and the contributing editor of the East magazine in Singapore before moving to the United States. When in AKMG, when I was talking to Dr. Pillai and we were thinking about getting a keynote speaker for the Women's Day program, I immediately thought about Dr. Jha, just because all her literary contributions have been to empower and inspire women, be it the mother and son's relationship in her novel, How to Raise a Feminist Son, that was published in 2021, that has been translated in Spanish, Portuguese, and German. Her debut novel, Foreign, that was published in 2013, which is a heartwarming tale of maternal love. And in her new novel, The Laughter, that was just published last year, Dr. Jha narrates the story of a young, dynamic female professor, even though it was written from the male's version. And this professor, she hails from Pakistan, navigating the professional scenarios in the US. And this book, the novel, The Laughter, it has been longlisted for the 2024 Aspen Words Literary Prize and is named one of the best books of 2023 by the New Yorker and the NPR. So in addition to inspiring women through her writings, Dr. Jha engages in teaching essay and fiction writing through the Hugo House, Headsbrook Writers Retreat, and the Seattle Public Library. Welcome, Dr. Jha, to today's program, and I look forward to a heartfelt discussion. Welcome.
Thank you so much, Dr. Pullarkat, and thank you to your association for inviting me. This is, and it's among so many incredible women, and I think a couple of men as well, but so many accomplished and engaged women. So I'm very, very excited to talk to you.
Great, thank you. So just to begin, can you give us a little bit about your background, what you're
Yeah, sure. Yeah. There's so many stories that we are able to tell about our lives and our work and everything. But, since we're talking today about resilience and joy, I'll focus on those aspects. Like as you mentioned, I was a journalist in Mumbai and in Bangalore, grew up in a middle-class household in Mumbai. My father was in the army, my mother was a teacher and then a hotel executive. And so, I was part of that generation of modern Indians, Indian women that, was going to have it all. I was going to have this beautiful life as a wife and mother, and I was going to be this professional writer, and I was going to live in India. I had no ambitions of going anywhere except staying in Bombay. So, but life sort of has its way of doing different things, and I think for me, what has been really important is knowing where to find a grounding and be grounded, and then also knowing when to take a risk and jump. And I think part of the resilience is to take those risks when they come about, and to be fearless, but also to bring along other people, bring along especially other women, and create this sort of solidarity and depend on it, learn to ask for help, and break a lot of the taboos that we have growing up in our culture in India, and also keep like your core, so I think that's really what my story has been about. I was trained as a journalist, and then I'm an academic who's done traditional academic publishing, and you're not supposed to talk so much about yourself and talk about your own life. However, for me, it's become increasingly important, because I feel like when I was growing up, if I had known of women like me that have found joy and happiness and are doing unconventional things and still finding those things, I would not have been as afraid, I mean, I think I was fearful when making certain life choices, but I had to sort of like feel my way around on my own. But to have a role model or many role models would have been very nice, and knowing that there are alternative ways of being successful would have been very nice. So anyway, I know there's a lot of vague terms, but I hope that's helpful. Oh, I think I can't hear you, Dr. Pullarkat.
Yes. Thank you. Thank you so much. You touch on a very important point, right? Growing up in India, as a girl, you always, I mean, not always, most of the time, it's like, it's a very low risk, the way you're brought up is, don't take too many risks, just do the main core things, don't reach out too much, because I guess, people are afraid that, especially for a woman, right? So I think that is something very important that you brought out. The fear of, it's just fear of failure, right? In that sense, it's always like fear of failure. So tell me, how do you talk about, like as women, we are vulnerable and strong at the same time. So what is your opinion about that? Yeah, can you just talk about it? Especially, we as women, we do so much, but at the same time, we just feel so vulnerable. What is your experience?
Yeah, absolutely. And as Dr. Pillai was pointing out earlier, that we've got all these roles that we play. We play, we're mothers and we're keeping these home lives. We are also community builders, we remember people's birthdays. We remember, the distant sister-in-law is getting married and we get involved. And, there are all these different roles that we play, and we also are accomplishing at work, right? So I've come to a point where I feel like, yes, I've done all those things. But also I think it's a time to look at the word resilience, and look at this thing of, oh, she's so accomplished and she's a hero and she does all these things, but also how much rest are we getting? Are we getting enough rest? Are we able to pamper ourselves? What does self-actualization mean to women? Is it just like keep on achieving? No, what's the next thing? What's the next thing? Or do we also get to be in solitude, be by ourselves, be taken care of, and not in the traditional be provided for or anything, but also, sort of maybe fail, maybe like rest and fall and say, oh, I'm not going to be able to do this, So for instance, for me, driving on the highway, like I was in a bad car accident and had PTSD and everything. And so everyone is like, oh, you're so good at everything. You have climbed so many mountains and accomplished so many things. You can totally get over your fear. And I said, no, you know what? I'm going to hold on to this fear. I'm going to let myself have this one thing that I refuse to challenge myself to get over. Okay. And everyone else can now drive me. When I need to be driven, my friends can come and they can, if you've invited me to go on the highway, you come and fetch me. And the thing is that it works, you know. I think when we say like I also am important enough to fail. I am also important enough to let go and be pampered and not come through for everything. People come around. So I've really come to this point where I feel that women need to let go of certain things and invite others to be in support and not constantly be telling ourselves, this is resilience, you can do it, you can do it.
True, great. Yes. And also, it's always like we feel like we have to sacrifice, right? We have to, play this role of Jhansi Ki Rani, right? We are the ones that who have to maintain the family, sacrifice. So you're right, at times we have to say, this is my thing, my space. I also need to take care of myself.
True, yeah.
So let's go back a little bit. And, in your memoir, which I should say, How to Raise a Feminist Son, probably it's chapter 12 or 13, you had kind of described your experience leaving India, moving on to Singapore, leaving things behind. So yeah, can you just elaborate a little bit about it and what were your thought processes and how did you cope with that?
It's more like an invitation to not live the life and in order to raise a feminist son, and my son is a feminist, and he's a really wonderful, tender-hearted boy, and I was doing this as out of love for him so that he can also stay soft and stay a kind-hearted person who doesn't have all these pressures that we put on men, even to be protector and provider and all of that. So my thing was that I was not going to be a self-sacrificing mother. I would be a self-actualizing mother. And he has seen that. And so he expects that in women too, that you self-actualize, you don't have to self-sacrifice.
Okay, got it. So, so through your, your position as professor in journalism, what do you think, looking at the young women who come your way, so what do you think is maybe some of the, problems that the young women are facing these days? And is it different from what we went through, or, how do they cope with that? Can you just elaborate on that?
Yeah, more than difficulties, I think that it's such a joyful time. It's so lovely to watch young women take up space. And I think that's the most important thing. A lot of us have been minimizing ourselves. And yes, of course, we do really well in our careers. But, there's so many things where we feel like, oh, don't laugh too loud. Don't be too ambitious. Don't be this and don't be that, right? And I think young women are finding themselves, just taking up space and insisting on certain things and also having joy and fun. And I think I really, really like that. And also not killing themselves as doing it, right? Like there's this thing of like, oh, you are, women can take so much. They're able to suffer so much. No, they're like, no, I don't want to suffer. I don't want to, be that kind of resilient. I think it's not a woman's lot to suffer, where we think like, oh, she's so strong, she can suffer. They're not taking it. And so I'm really excited to see that. And I think I'm learning from them even, I find that. And they're also, we're not, none of these, I was never like a man bashing or anything, but also calling out the patriarchy, right? The patriarchy is a system. It's not individual men, and it's not only men, it's women as well, right? So but understanding patriarchy and saying like, no, this needs to change. And it's good for everyone. It's good for all genders. It's good for men. I've seen that dismantling patriarchy, which a lot of young women are doing, is also good for men, because men feel like, okay, I don't have to keep performing this role as either, right? So, and I don't have to always be angry or tough and all of those things. So I think a lot of young women are carrying that forward, and all power to them.
Great. Yeah, that's so nice to hear. And I see the same thing in my profession. So, women of these days, they live for themselves, not living, for somebody else, but, trying to accomplish things for themselves and for the community, not because of something that's been set right for them. Yeah, it's true. So coming back to your book on, how to raise a feminist son, how would you, in your definition, how do you define feminism?
Oh, that's a great question. To me, feminism is not just about women. It is about the liberation of everyone. So it's about the liberation of all genders. We're talking about equity. We're talking about equal opportunities and, equal pay for equal work. We're talking about equal joy, equal opportunities for, rest, equal. And so what are the things that are stopping that? So for me, a feminist is someone who's invested in say, trans people's safety as well, right? Which is not just for women, is invested in Black Lives Matter, is, looking for and is also interested in her son or the men around her and saying this freedom is for you as well. And is calling out patriarchy or resisting it within herself as well. So a lot of us have internalized sexism, right? Like we inside ourselves, we'll think certain things about certain kinds of women, and I have to catch myself. I'll think those things about myself, like, oh, I should not eat ice cream. I've put on 10 pounds, and it's like, yeah, I've put on 10 pounds because I'm in my mid-50s. Also, if I don't relax now, when am I going to relax? It's okay as long as it's not, getting totally unhealthy. I'll watch the numbers and everything. But not constantly doing that, learning to celebrate and all of that, and not internalizing and turning patriarchy upon ourselves and our sisters and brothers, right? So for me, feminism is, the definition of feminism is very expansive. It's not limited to just women's empowerment. Yes, definitely women's empowerment is the focus because the structures still don't allow for that. But I think bringing everyone along.
Okay, so I'm not sure who said this, but they said, if you want to have women who can live their lives in today's society, you have to raise sons the right way, right? So
absolutely, because one of the things too is that sons, like, I have to catch my son too. He mansplains a lot to me, right? So I have to catch him, and I have to say, dude, I already know about publishing. You don't have to tell me all these things. I have first hand experience, but at the same time also, and also telling him, to have not just respect, but also speak up at work, for instance, right? If you see that some woman is being sidelined or does not get the promotions and everything, what are you doing on an everyday basis to empower women around you, and also to get out of their way? If you feel like, someone else deserves to speak up at this moment, what are you doing to get out? And it's not about going later to her and saying, I didn't like how you were interrupted in that meeting. You say it in the meeting and say, look, I think we just interrupted so and so, let her speak up. So all those things I think are really important, because women can keep being powerful. We have been empowered for a long time. Okay, we have no problem being empowered. We've generations, our grandmothers were even empowered. It's men who will refuse to give up power. Look at
yeah, thank you. That was a good thought. Yeah, and also the other thing, well, in AKMG we've been having female presidents for quite some time. So yeah, going back to your memoir, I think that is a big contribution that you've done to women, talking about your vulnerability. You went through a time, just mentally, you're feeling down. So I think growing up in India and for South Asian women, we are taught to not, talk about, feeling mentally vulnerable, looking for help. So I guess that's something important that today's women have to realize. What is your opinion about it, right?
Absolutely. Yeah, absolutely. So mental health, for instance, is a really important thing, and we don't talk about it because, we think of it as shame, and we're bringing shame on our families. We're saying something was wrong with our families. Something is wrong with all families, right? And I think all of us, especially growing up in India under a patriarchal culture, and I'm not saying the US doesn't have, US is very patriarchal and it's racist. And so there's, multiple threats here. But I think growing up in a very patriarchal culture and managing that, and then being told like, now you're free, now you can do what you want, is a very taxing thing. And I think we need to be able to, especially for the sake of our kids. So there's a lovely book that an author friend of mine has written, and it's called They Called Us Exceptional. And it's called, They Called Us Exceptional and Other Lies That Raised Us. That especially in the US, there's this thing of how South Asians especially, and definitely South Asians are exceptional. Like, we are the high performing people and we're doing all these things, and the toll that it takes, and it's got its roots in colonization, right? Like, oh, this is the model minority, they're making themselves useful, etc. But the roots of that, the toll that takes is on our mental health. And the author Prachi Gupta, she's a young woman in her mid-30s, and she talks about how her brother faced a lot of pressures, because of that kind of exceptionalism, that it doesn't allow. We don't allow our kids to just be normal and mediocre or average. Each one has to be exceptional. You have to achieve. You have to achieve. What is that all about? And why do we give that pressure? And are our kids not worth something if they are just going to be average? They still get to live beautiful lives. And so I think having that and seeing that the toll that it takes on their mental health is really important. And we need to let our kids go to therapy, and we need to go to therapy ourselves.
Good point. So, and the other thing also that I'm impressed about is, the pen is powerful, more powerful than a sword. And I am so impressed that you're involved in, teaching writing to the young generation, especially women, right, through your, involvement in the Hedgebrook, because I think it's important. There's a lot that we can do through our writings, and which probably is, to kind of engage the mass. So I guess that's very, very important. And I'm myself as a person, and I'm so thankful to you for taking that initiative to allowing more and more women to, think about what's going on in the current society and just writing it down and, spreading the word. I think we are out of time. I'm not sure if anybody, do we have any questions for Dr. Jha?
Sheila, I don't have a question. I have a comment on what Dr. Jha just now said very, very eloquently. Thank you. What you talked about feminism really touched me. And in many circles, especially now, my age group, feminism is a little bit not that a good word to use. Oh, she's a feminist. But what you said, that equal opportunity for everybody, expansive and empowerment for all, that is something message we need to give when people give us dirty glance, when we said, yes, I am a feminist. I'm proud to be a feminist. So thank you, Jha. It was a wonderful, wonderful.
Thank you so much. I'm so glad that resonated. Thank you.
Thank you.
Okay.
Oh, yes. And Dr. Jha, I can't thank you enough for, taking the time today to, talk to us and just, share your experiences with us. And I know that you have another engagement after this. So once again, on behalf of our president, Dr. Pillai, and the AKMG and all the women, my sincere and heartfelt thank you to you. And thank you for coming. And, I hope to talk to you in the near future. We are acquaintances, and I hope to, get to know more about your publications in the future and, just let you know how proud we are of your work. Thank you again.
Thank you so much, Dr. Pullarkat, and thank you to everyone here. It was a wonderful, wonderful, very welcoming event. Thank you, and happy Women's Day to everyone again. Bye-bye.
Thank you, Dr. Jha. Thank you so much. Thank you for celebrating Women's Day with the AKMG. Thank you again, and for that inspirational session for us. Thank you again.
Thanks. Bye-bye.
Next, we will have our next session.
Okay.
With back to you, Kamar.
Okay.
For our next session discussion.
Okay. And before that, thank you, Dr. Sheila, for wonderfully moderating the prior session. Anyway, next is Dr. Oormila Kovilam. She is a senior faculty. She's a senior faculty in maternal fetal medicine, subspecialty of OBGYN, the University of Illinois College of Medicine in Champaign. She has a very prestigious academic career and has worked as directors for maternal fetal medicine division at the University of Cincinnati, Creighton University, Nebraska. She trained students, residents, and fellows. She is the recipient of several prestigious teaching awards from American Board of OBGYN, as well as a Hospital Hero Award from University of Cincinnati for his service and outstanding contribution to care of the critically ill pregnant mothers. It's truly a privilege and an honor to welcome Dr. Oormila Kovilam and have her share her expertise, her knowledge with us on perimenopausal issues. Oormila Kovilam, it's yours.
Thank you so very much for those kind words. Let me thank each one of you for being here on this beautiful Sunday afternoon. You should be out playing and enjoying the sun, but we are here. Hopefully, I can make your minutes a little bit more informative and useful. Thank you, Dr. Sindu Pillai, for your relentless work and putting these things together on a consistent basis and trying to make us each do better and reaching out to us.
Happy birthday എന്ന് പറഞ്ഞ് നിർത്താം അല്ലേ?
Okay. Can you hear me?
Can you mute if you're not speaking? I'm sorry, Oormila, 1 second. If you're not speaking, please mute yourself. Thank you, Oormila. Sorry about
Okay.
that.
No, thank you. Thank you again, Dr. Sindu, for putting us all together and making us think and participate. At the outset, I want to say my subspecialty is maternal fetal medicine, and I'm not a reproductive endocrinologist, but I wanted to take this opportunity to share some thoughts on perimenopause because all of us go through it and endure it and day by day. And then I had the privilege of working with some of the giants in this field. Dr. Marjorie Gass, who was the president of the North American Menopause Society, and also with Dr. James Simon, who's a great advocate for women and the transitional years. So I thought, well, I'll try and I'll also update my knowledge along with all of you. So this is going to be a very fast, short presentation. Menopause is no bullet therapy, and I'm not a bullet train to finish this whole topic in a few minutes, but there will be a lot of holes, so you can approach me later, and the slides are shared. So let us go through the next. So menopausal transition. I want to tell you that human species is very, very unique. Human menopause is a big mystery. Ovaries give up faster than the rest of the cells. They stop having children, but go on living. But when compared to the other mammalians, like the whales and elephants, they are well into their reproductive age until 60s, 70s, but the human beings, 40s, 50s, the only other species that we have in common is the orcas. So why do we have this sudden stop? We do not know. And are we destined to be just babysitters after some time, or wise old grannies? We do not know. But I think looking at some of our senior leaders, I think it's going to be leaders with wisdom. So what we have learned from the orcas is they live up to some time, but when there is a famine or dearth of food, they go to the oldest person in the oldest female orca to lead them to where food is available in plenty. So I think it's also a part of wisdom. So innate ovarian expiration, there is no date set, but we know it is somewhere controlled within the womb. We know after hysterectomy, sometimes ovarian functions wane, even if we keep the ovaries. So there is this thought when you come to perimenopausal, like 50s, if you're doing a hysterectomy, why are we keeping the ovaries just to be there later for ovarian senescence or evolution to malignancy? So that is one of the thought process. So to coming to the definitions, menopause is end of menstruation due to loss of ovarian function with alteration of ovarian uterine axis, and it's usually diagnosed after 1 year of the last menstrual period. And it can go through several transitions. There could be a late transition where you're still ovulating, the woman may be still reproductive, so you need to use some birth control pill. That's the biggest mistake that we think, oh, we are having irregular cycles, we're not going to have children, and then you have this baby in your late 40s. Then you have the early menopause transition and the late transition, and then the last phase is the early menopause. So when you look at this hormonal levels, you see this is the normal. In the pre-ovulatory phase, if the estrogen is building up, then there is the LH surge from the hypothalamus, triggers ovulation, and the progesterone increases and there's decline. But in the postmenopausal phase, when we look at it, look at this, the FSH is rising consistently. And this is one of the reasons for the hot flash and the vasomotor symptoms. And in the premenopausal, look at the ovary with nice little follicles, whereas in the postmenopause, the ovary is just a bunch of scars. So I just wanted to show you this. And when we come to the menopausal symptoms, where there is woman, there is always magic, but there's also misery when we go through this menopause. So I'm not going to enumerate all of this because it's so varied. It affects every system, every cell in our body is touched by hormones, estrogen, and especially estrogen more than progesterone. There are factors which affect the age at menopause: genetics, ethnicity, smoking, medication, lifestyle, everything. And, you know, I wish I could take a picture of my young self and my old self and compare one of my pictures with the young AKMGs. You can see the predominantly when you look at your face, you know, the lines and the lack of vasomotor support and the wrinkles. I want to call it the wrinkles of wisdom or the lines of wisdom, but it is truly a lack of hormonal support. We will touch upon a few of these symptoms that we can treat. And this again is the premenopausal physiology. In the early follicular phase, the level of the estrogen is low, but during ovulation, it goes as high as 200 to 350. What I want to tell you is in the postmenopausal phase, it is as low as 5 picograms. So you can see the wide variation in fluctuation in the hormonal levels. So you can imagine what's happening. And this is in a normal. I always like to compare with normal. Then only will you understand the gravity of the problem that we are facing. This high levels of hormones. Look at this endometrium. It after menstruation, it is thinnest, then it keeps on proliferating. But in a postmenopausal woman, look at this. This is so thinned out. The vaginal epithelium is so thin. In a premenopausal woman, there are like several layers, 5, 6 layers. In the postmenopause, it's just basal cells and parabasal cells. So when you take a smear, you know, the oldest thing that we had to do as residents in India, I did an OBGYN in India, we had to always do a vaginal smear and do this karyopyknotic index and count the number of basal cells, the superficial cells, and make the ratio, and then diagnose menopause. That is a very neat outpatient hormonal assay, and I don't know why we can't do it. You know, because when these women come with a little bit of bleeding, a little bit of symptoms, we don't know whether we need to start treating or not. And it's very, very important. If you have to have any gain in therapy, it has to be in this early phase. And why does hormone replacement therapy undergo so much of queries? It is the biggest controversial subject. And, you know, the University of Cincinnati, when I was in training and during fellowship, the biggest topic was the Women's Health Initiative discussion and topic and recruitment for women. There were more than 70,000 women recruited. The thing was like, you know, should we give hormones or not to give? The problem in the Women's Health Initiative study was most of the results reported were among women over 60. The mean age of those women was 63. So we found increased cardiovascular disease, increased malignancy. And in 2002, it came out and it got such a bad report. Everybody suddenly stopped using hormone replacement therapy. And most of these women became miserable who couldn't afford. The most important thing is we should recognize this early and start treatment earlier. So for earlier involvement in therapy, we need to have an earlier diagnosis, and women should have awareness. That is what we can do as primary care, and that's what we can do as women and elder women. Talk to the younger women when you're going through this phase, not to keep it as a silence and not to suffer in shame, but to come out and say, I'm having this, what should I do? So that is the most important message I have to provide, because if you want to intervene, we have to do it in a timely fashion. Please feel free to stop me, okay? Because I think I'm running out of time already. See, this is the histopathological changes. The proliferative endometrium, the lining is getting thicker and thicker. So if you're bleeding a lot during a menstruation, you know that its lining is getting thicker. during the after ovulation. This is beautiful secretory cells with all these glycogen ready for the eggs. If, fertilized egg. If not, it is shed. Look at this postmenopausal endometrium, very atrophic. But sometimes it can collect fluid and cause serosal bleeding, and it can cause malignancy, and it can cause polyps. So this is on ultrasound, very thin, 1 to 2 millimeters, whereas during reproductive phase, look at this endometrium. So one look on ultrasound, we can easily diagnose. A transvaginal ultrasound is a very, very important tool in our hands. So what are the other evaluations? You have to, symptoms are vague and varied. People don't tell you if you don't ask them. So besides a detailed history and physical examination, we have to ask them for cardiovascular symptoms, measure bone density, malignancy screening, the breast cancer, endometrial biopsy before initiating. See, most of this time in the earlier studies, because they were not evaluated appropriately. So that was not available in the Women's Cell Initiative result. How were these women recruited? They just said a 63-year-old women, about 60. But what did we do before recruiting? What did we do before treatment? That is not known. And always we want to do a complete metabolic profile. Thyroid function. You could have thyroid abnormality and irregular bleeding. That could be a reason. And we need not conduct hormonal assays, estradiol, estrogen, progesterone, FSH. We don't have to do all that if you have a clinically sound history and normal ultrasound and normal basic labs. And reassess every 2 years. You don't start them and then forget about them. Always call them back. This is the Women's Preventive Service Initiative Well-Woman chart, where all the primary cares have to do for age 40, 50 to 50, 64. I leave this to the primary cares too, because in the interest of time, definitely do lipid screening, do cardiovascular screening, because you want to be careful before you start hormone replacement therapy on that. This is again the cancer screening, which I will not touch on now. We said differential diagnosis is very important as premature ovarian failure. Why is this important? Because we need to treat these women. This is one group or subset of women that we need to treat and they benefit from them. Because if you don't treat, they can have increased risk of fracture. And ovarian toxin, genetic autoimmune injury, these are the reasons for, and chemotherapy, alkylating agents. Methotrexate usually don't cause that much of ovarian failure. I know we use that a lot in ectopic pregnancy. So again, what brings these women to the doctors is mostly the vasomotor symptoms, variation over transition. I'm not going to go into the detail of all this. If we have suffered it, we know what it is, these vasomotor symptoms. Look at this variation. This is from year 0. If you go backward for 10 to 11 years and forward for 10 to 11 years, there are people who suffer over for 20 years. There are people who suffer for 10 years. There are people who suffer less. So it is a lot of variation. So we have to ask these women, what are your symptoms? There's a miniature hot flash detector. It was created by Dr. Friedman. And he recorded the symptoms and he can qualify. They also do this for men, because men sometimes testosterone functions and, we don't know whether they are suffering. We need to know. So this is equity, okay? So we're going to check men too. So menopausal hormone.
Dr. Oormila, you have 5 minutes more.
Okay.
Sorry about that.
Okay, I know this is a vast. So menopausal, what are the pros and cons? These are the important things. Should we start or not? Combined hormone, the benefits are usually in women 50 to 59 years. The absolute risk for women, if there's no contraindication, the benefit is better, okay? So significant relief, decrease in colorectal cancer, decrease in fracture. Estrogen alone, decrease in vasomotor, quality of life, again decrease. There's no increase in breast cancer, no increase in endometrial cancer in people who are low risk. This is again showing the studies. I can skip that. And this is benefit versus risk for 50 to 59 years. This is in a table form. Therapy guidelines. When do you start treatment? Under 10 years of menopause and women less than 60 years. With lifestyle disruption, genitourinary syndrome, atrophy, okay? Contraindications are breast cancer, cardiovascular, and prior thromboembolism, stroke, liver. This is the most important point. You don't do that. In the preparations, you have oral, transdermal, gels. There's a huge list here. I have provided all this for you that is available in the United States, and I can skip that. Why do we talk about progesterone? Because we can, when you combine with transdermal, estrogen, you can also use prometrium, which is a good one, and we can use a intrauterine device delivering progesterone. That could be a very good one to prevent endometrial hypertrophy. So these are the things for local genitourinary syndrome. This vaginal rings is a very good thing, delivering local estrogen, lasts for 90 days. Vaginal tablets, vaginal cream. Vaginal creams are very useful tool. And oral versus transdermal, again, transdermal is very low dose, increased bone density without a thromboembolism and less effect on lipids. So if you have any patients that who are hesitant to take oral, please initiate transdermal therapy. And this is a new medication to block hot flash and vasodilation. It's got the fusolinant, and it blocks the NK3 receptors in the hypothalamus preoptic area. So this is being available. If you request, certain pharmacies will help you. This is an important question. What are bioidentical hormones? After the Women's Health Service came out with the study, we switched from estradiol to bioidentical hormones. But there is a lot of myths about this bioidentical hormones, is because you can't monitor them. But if you have FDA approved bioidentical ones, then that is better, but not the standardized one. There are different formulations. Natural doesn't mean absolutely safe. And these are the forms that I have enumerated here. Genitourinary syndrome is very, very important symptom. And you have to rule out vaginal atrophy. You have to rule out recurrent infections. And there is even a computerized program now. AI helps you to differentiate between vaginitis and plain genitourinary syndrome. Vaginal dryness treatment is very important with vaginal estrogen therapy, refresh, replens, lubricants, and all of that. It's most important thing to take care of the hormonal treatment, then the local lubrication, then the dilatation. It could be with artificial dilators or natural dilators. So vaginal dryness. Differential diagnosis is very important in patients who have had hysterectomy, ovarian failure, who are on medication. Tamoxifen, danazol is very important. Postpartum, we forget about postpartum period. Hyperprolactinemia and lupus, rheumatoid arthritis, prolonged steroid treatment. These are all what the common physician has to think of. And most of the time, use of tobacco. 70% of our patients do not discuss. It's very important that we ask them. Compassionate history taking is a must, and any woman 35 and above, you have to include this in your questionnaire. You have to look at the vaginal pH along with treatment. It's just hormone therapy is not sufficient. You may have to correct the vaginal pH, because higher pH means increased infection. So we need to do that. Immunofluorescence, this is called the DAISY Vaginal Health Assessment aided with artificial intelligence. It's got 90 to 95% accuracy. It's not 905, it's 95%. And you have to rule out allergy to perfumes, panty liners, pads, lubricants. Use skirts, not hot pants all the time. Sari is a good tool too. Then in genitourinary evaluation and treatment, androgens play a very important treatment, because testosterone can increase well-being, decrease fatigue, help with libido, bone loss, and also help with cognition and memory. These are some of the pictures of patients undergoing vulvovaginal atrophy with fissures, desquamation, urethrosil. This is a toxic erythema undergoing chemotherapy. How can we not treat these women? How can we turn our backs to them? We really need to take care of them. Postmenopausal osteoporosis is a very important thing. It silently breaks our bones and kills us and lead us to our grave. But we can prevent this with early intervention. You have anti-resorptive agents, bisphonates. Everybody knows about this Fosamax. You have raloxifene. The newer ones, if you're 60 to 70 and has never had previous treatment, this is anabolics called Forteo.
Dr.
And
Oormila, I
okay,
think
we'll stop there.
Yeah, please.
Okay.
We have
Okay.
2 more speakers, and okay.
Okay,
Thank you
that's
very
fine.
much. We have a general question and answer at the end of the session, and
Okay.
please, stay and if you
I
can.
know this is a huge topic. Okay.
Okay. Thank you. Thank you. Okay. Our next speaker is the dietary facts and how well we understand. by Shubha Anand. We have a very eminently qualified dietitian and as our speaker next. She had her training in both graduate and master's level in nutrition and dietetics. She's a registered dietitian from last 35 years. And currently she is the Director of Food and Nutritional Services at Corona Regional Medical Center for the past 17 years. She enjoys traveling, watching cricket and basketball. And here is Shubha Anand. Also, I want to say we have a very interesting subject coming next after Shubha Anand about a needle therapy and all. So please stay on. Shubha, it's yours.
Can you guys see my screen?
Yes.
Okay. So again, my name is Shubha, and I am humbled to be invited to this forum. After the two distinguished speakers, does start my video? Do I need to do? The host has asked you to start your video, so I do. Oh, sorry.
Shubha, keep the video on. Yes, we can't see your face.
Okay. Okay. Oh, sorry. Anyway, so my again, after the two distinguished speakers, I hope I do justice to. So I'm going to go piggyback on the I don't know how to change okay. So we just spoke about diet, menopausal women. And so I'm going to go directly into the diet and osteoporosis and for postmenopausal women. So like Dr. Oormila said, an estimated 50% of postmenopausal people do experience osteoporosis. And Dr. Oormila, if I'm wrong in any way, please correct me. And menopause is one of the most common cause of osteoporosis, which again, like Dr. Oormila said, estrogen is a hormone that plays an important role in maintaining bone strength. Menopause involves the ovaries that no longer produce estrogen. So I'm going to go to the nutrition part therapy. So calcium and vitamin D play a role to prevent and treat weak bones. So the recommendation is to increase calcium to about 1,200 milligrams per day. Bone loss and fracture risk increase in postmenopausal women when dietary intake of calcium is less than 700 to 800 milligrams per day. Vitamin D, you can get it through sunlight, food, and supplements. One of the things that I have to say about calcium, we all know that milk is very high in calcium. A lot of Asian population, especially South Asian population, we are very lactose intolerant. And somehow that is, I'm just talking about myself. I was fine drinking milk, but as I grew older, I became lactose intolerant. So that's when I think we need to look at supplements. Our diets include a lot of yogurt, which is very good for us, and it's a good source of calcium. The fish eaters, a lot of our fish eaters, it's also a good source of calcium if you want to chew on the bones, if you like the bones. Okay, so calcium benefits, supports bone development. The deficiency reasons, again, like I said, menopause. Deficiency signs are typically asymptomatic. Long-term is osteoporosis. Foods that are high in calcium are milk, eggs, and yogurt. Vitamin D, necessary for healthy calcium absorption, bone mineralization, and bone growth and remodeling. Deficiency reasons, not getting enough vitamin D in your diet and or through sunlight. And this vitamin D deficiency is very common again in the Asian population. And one of the reasons being, we don't like the sun. We try to preserve our color. We think that, you know, if you go out in the sun, I mean, think of us growing up as children in India. We were never allowed to go out in the sun. Oh, you're going to get dark. Look at the way, if you go to the beach, how many of us go to the beach during the day? We don't want to go to the beach during the day. We want to go to the beach in the evening after the sun sets, because again, we are afraid that the sun is going to make us darker. So again, that's just one of the reasons. Again, the deficiency signs are bone pain, muscle weakness, and fatigue. And again, so the foods high in vitamin D are salmon, egg yolks, mushrooms exposed to sunlight, and fortified foods. Fortified foods meaning like cereal and stuff like that are very high in vitamin D. So I know these topics are all very different, but these were the topics I was asked to speak on. So I'm just going to briefly touch on sarcopenia. So what is sarcopenia? Sarcopenia is a type of muscle loss which gradually starts in your 30s and 40s and picks up between the ages of 65 and 80. Now, during aging and menopausal transition, a progressive muscle degeneration occurs, which can then lead to sarcopenia. Sarcopenia, again, is a generalized skeletal muscle disorder that is associated with increased adverse outcomes, which may include falls, fractures, physical disability, mortality, and stuff. How to prevent it now? Exercise is the best, and resistance training being the best to prevent sarcopenia. Routine physicals are very important for everything. Make healthy food choices, maintain a healthy diet that includes high quality proteins. Lean meats such as chicken, turkey, beef, and pork. I know you guys will say beef and pork are not lean, but there are lean portions of the beef and the pork. Fish, milk, cheese, yogurt, eggs, nuts, these are all good sources of protein. Supplements such as creatine, vitamin D, and whey protein also help to preserve body mass. Omega-3 supplements are also very good to prevent sarcopenia. Aim to have at least 25 to 30 grams of protein each meal. My next one is, I've been asked to speak, is about vegan diet and B12 deficiency. Now, the problem with the vegan diet is it's very deficient in vitamin B12 because none of the plants do not make vitamin B12. So people who are on a vegan diet have a higher risk of B12 deficiency. Plant-based diets in any form are becoming increasingly common in the Western society. I mean, just in the hospital, when I first started, I never heard of, we would get vegan and vegetarian were mostly Indians. And, those were the diets. But now when I look, we have so many vegan diets that we have it in our, in the ordering system. So this has become very popular. There's a lot of restaurants that have, are vegan. So veganism has become very, very popular. Therefore, vegans need reliable sources of vitamin B12 as fortified foods or supplementation. Vitamin B12 deficiencies include cognitive, and the signs and symptoms are cognitive changes such as depression, memory impairment, confusion, psychosis, and fatigue. Neurological complications such as loss of sensation, muscle weakness, or loss of mental and physical drive. How do you enhance vegan diets with vitamin? Eat fortified foods 2 to 3 times a day to get at least 3 micrograms of B12 a day. Fortified dairy-free milk, including oat milk and soy-based drinks, also have vitamin B12. There's a nutritional yeast called Nooch that's also high. Or take 1 B12 supplement daily to provide at least 10 micrograms. weekly B12 supplements providing at least 2,000 micrograms. Okay. My next topic is, again, misconceptions about over-the-counter dietary supplements. So I'm just going to do this. Fact or fiction, biotin supplements have gained popularity with those seeking stronger, healthier hair, skin, and nails. Fact. Fact or fiction, the FDA has warned that taking biotin supplements can alter results in medical tests, including anemia, cancer, heart disease, pregnancy, and thyroid problems. Fact. Adults need 30 micrograms of biotin each day to avoid a deficiency. Fact. Turmeric supplements are loaded with antioxidants and improve cardiovascular health and reduce inflammation. Fact. Turmeric is best when used from the fresh root. Fiction. Recommend a full spectrum turmeric supplement. This way you know how much you're going to get in every capsule. Now, for some of us who use turmeric in our daily cooking, that should be enough. Facts regarding zinc, and zinc, we promoted zinc a lot during the COVID times. So zinc is a trace element, which means you only need a very small amount each day. You can get this by eating a well-balanced diet, and you can take a zinc supplement. Zinc also plays a role in immune support, wound healing, reproductive health, insulin regulation, protein, and DNA synthesis. Men need about 11 milligrams of zinc a day, while women need 8 milligrams a day. People who are pregnant or breastfeeding often need about 11 to 12 milligrams per day. Again, facts about dietary supplements: more than 1/3 of Americans do take supplements. The most common supplements contain fish oil, omega-3, DHA, or EPA fatty acids. About 30% of adults ages 65 and older take more supplements of any kind. Lastly, and nothing beats the nutrient power of a healthy diet, and that's where, as a dietitian, I would say, get most of your nutrition from your food. Okay. And the next one is the benefits of red wine that everybody wants to know. How much of wine can I drink? So red wine is found in all these Cabernet, Merlot, Zinfandel, Malbec, Pinot, Sangiovese, and Nebbiolo. So what red wine and resveratrol? So that's basically what it is antioxidants in red wine are called polyphenols. A polyphenol called a resveratrol is one of the part of red wine that's noticed to be healthy. The facts about it is that they help prevent damage to blood vessels, low density lipoprotein, LDL, cholesterol, and prevent blood clots. The resveratrol in red wine usually comes from the skin of the grapes used to make the wine. Other sources, you don't only get it from wine, you can also get it from red and purple grape juices, peanuts, blueberries, and cranberries. The other red wine benefits, they decrease blood pressure. I'm done.
No, you're not done. No, you have 5 minutes more. Okay.
Oh, okay. Heart health helps reduce the risk. It helps reduce the risk of plaque buildup in the arteries. Cancer risk reduction may reduce the risk of cancer by discouraging cancer cell growth, including colon and prostate cancer. And it also reduces the risk of Alzheimer's, but we need more research on that. And that's all I have.
Wow, Shubha, you beat the time.
Yes, I did. So if you guys have any questions, always feel free. Thank you so much for letting me present. I hope I was of some help to all of you.
You were to me. Sindhu, you want to say anything? We have a couple minutes.
Yes, thank you so much, Shubha. That was a wonderful session. A lot of information, and also you covered almost everything people want to know these days, and especially with the veganism, the vegan diet, and the red wine, and definitely the adding protein as we get older, and you covered almost everything that people want to know. Very, very helpful to me as well. Thank you so much, Shubha. Thank you for accepting our invitation, and thank you hats off to Dr. Sheeja Pullarkat to introduce Shubha to our AKMG, and thank you for educating us regarding nutrition.
Thank you
Wonderful,
so much.
wonderful.
Thank you again.
Thank you. Thank you.
Okay. Next is a subject many of you have privately shown interest and have corresponded with me. It is, better put my glass on. It's a needle phobia, management of acute needle pain, and for entrepreneurship for the doctors. We have Manju Dawkins, a board certified dermatologist, a chief resident at Albert Einstein College of Medicine, Bronx, assistant professor at Mount Sinai School of Medicine, twice named as Teacher of the Year, practiced in academic, private, hospital-based, and group practice settings in New York and Los Angeles. Well, it's not over yet. She's a creator and co-founder of Thimble, a first easy and comprehensive solution for alleviating needle pain and stress. But I will let her explain that one. Very impressive. Manju, go on.
Thank you so much. Let's see. How's that? Can you see my screen?
Yes.
Fantastic. Okay. First of all, I just want to thank you for this opportunity. Both of my parents are AKMG members, and so I've been a part of this community since I was born. So this is a very full circle moment for me, and I've learned so much from each of the speakers today, so thank you. My name is Dr. Manju Dawkins, and I am a board-certified dermatologist, mother of 2 girls, and the creator and co-founder of Thimble. And so I want to tell you today about how just being myself unexpectedly led me to entrepreneurship and rekindled my love of clinical practice. And I'm also going to speak to you about the importance of managing needle pain and anxiety. So I grew up on the East Coast in Maryland, and I loved playing basketball growing up. And my dream was to play in college. And, when I was in high school, my coaches thought, no, you're 5'2". I don't think it's going to work out for you. But when I got to Columbia University, I walked on to the Division I varsity women's basketball team and played all 4 years and ended up being captain. While I was at Columbia, my coach, my dean there, I should say, did not think I should apply to medical school. But I did it anyways, and I ended up at the University of Maryland. My dean there said I would never get into dermatology, and I did have to do an extra year of research, but eventually, as you mentioned, I trained at Albert Einstein, where I served as chief resident, and have been, really blessed to be able to work in different kind of practice situations. And so I've gotten a taste of a lot, and I'm really blessed to be where I am in Los Angeles today. But who am I really? Well, I'm a person who clearly thrives on underestimation, but I am a disliker of suffering. I don't like to be in pain myself, and I really don't like seeing other people in pain. Schadenfreude, meaning the idea of finding pleasure in another person's pain, was just never a thing for me. I was always that kid who was running away from the nurses and doctors wielding needles. I was a resident who loathed, biopsying children because I couldn't stand the crying. And I'm still that doctor that chats too much with patients. And, for much of my career, I thought all of those traits made me a bad doctor. But what I realized is no, all it makes me is just an empathetic human being. And, recently I've just decided to be exactly who I am, and I'm enjoying where it's taking me in entrepreneurship and in practice. So years ago, I experienced a moment that every parent dreads. I took my month-old daughter in for her first set of shots when I was a third-year dermatology resident. And when she got stuck, I will just never forget that look on her face. She looked up at me with pain and then betrayal, like, how could you let this happen to me? I felt like I had failed as a mother and as a physician. I didn't protect her. The reality is most kids are just like my daughter, afraid of needles. And let's be honest, no one likes needles. But did you realize now that 63% of adults has a fear of needles? Needle fear has skyrocketed over the past 3 decades, and with good reason. When I was a kid, I got 6 shots before the age of 6. My kids have gotten 36 shots each in that same time. Now, of course, this is a wonderful thing, right? We can protect better than ever from disease. But if we continue to ignore the pain and trauma that needle procedures can cause, there are consequences. So unsurprisingly, people fear and thus avoid needles because of the pain. The problem is they end up sicker because they can't get the vaccines, blood draws, and medications they need to stay healthy. So this is a study done by Becton Dickinson, who ironically is the largest manufacturer of needles in the globe. And as I mentioned, most people fear needles at this point. And what is happening as a result? 52% of those people are avoiding blood draws. 33% are avoiding vaccines, and 18% are even avoiding injections for severe medical conditions. So the COVID pandemic really magnified this issue. This Oxford study showed that if we actually addressed injection anxiety, we could have increased COVID vaccines by 10%. So to put that into perspective, that's 300,000 lives that could have been saved in the US alone if we'd done something about it. And it's unfortunate that we're here because back in 2015, the World Health Organization warned that unaddressed pain negatively impacts health attitudes, and that pain mitigation is an important strategy to counter vaccine hesitancy. But distressingly, we're not following these clear recommendations here in the US. Furthermore, when a patient's pain and anxiety is managed better, we healthcare professionals do better. And I think we've all experienced this firsthand, right? When you've had anxious patients, how much longer did that visit take you? And how did you feel during that visit? Were you able to execute the procedure as well as you usually do? So this study by Dr. Amy Baxter showed that when kids were pre-treated with EMLA for 2 hours in the emergency room, 76% of nurses reported easier IV insertion and had a higher success rate on their first attempt. And this is a good opportunity, little pearl for everybody in practice. Needle phobia is a billable diagnosis. So there's an ICD-10 code, which is F40.231, write it down. This can and should be used to increase your level of billing when you're discussing OTC or prescription solutions. And it's important to use this code because we need to show the powers that be how prevalent this problem really is. And that will encourage the incorporation of CPT codes so that you can start to bill for, the solutions that we create. Okay, so clearly there is an unmet medical need. Needle aversion is driving people away from healthcare, and it makes great sense, right? Pain's function is to warn us of danger. It tells us to move away from a stimulus. So it should be no surprise that with all these repeated episodes of pain, it kicks in the human instincts to avoid what causes the pain. So most of us, we use our higher cognitive abilities to rationalize going back over and over again. But I'd ask each of you to introspect for a moment. Have you ever delayed getting your family's flu shots, or questioned whether that booster was really necessary, or put off checking your own labs? There's no shame in any of this. This is all purely being human. I think all these negative experiences provide the fodder for skepticism and distrust that's really rampant today, and I know we're all feeling this. So how do we solve for this? So you would think, given the massive size of the issue, there would be a ton of solutions out there, but surprisingly, there's actually nothing marketed to patients to counter the pain of needles, leaving most people feeling pretty helpless. And what's most commonly used requires a prescription. So it's here on the bottom left, it's EMLA. It is a prescription cream, and the way it is used is you have to put a big glob of the medication on where you're trying to anesthetize. You need to occlude it with saran wrap for it to work its best, or Tegaderm, which are a little expensive. You need to hold it in place for 2 to 3 hours for it to work its best, and then the cream melts at skin temperature, so it migrates away from the intended site. There's also a risk of methemoglobinemia, which can be potentially fatal in infants. So there are a lot of issues to tackle. And this is the reason why I started Thimble. It's the first comprehensive solution for needle pain and fear. We know that everyone's pain is not acknowledged in the same way, and we believe that everyone deserves access to these solutions, and so that's why everything that we create is available without a prescription. So for us, it starts with the Prepare patch, which is a patent-pending drug and adhesive lidocaine-based patch that is specifically designed and formulated for needle procedures, and you apply it before the shot to prevent the pain. To follow, we have the Recover patch, which is a patent-pending plant-based patch. So this utilizes turmeric and arnica to alleviate the bruising, soreness, and ache that tends to follow. But we all know that pain is not just physical, right? It's emotional and psychological also. And so that's why we pair our patches with our app that puts together all the research-backed techniques and tools to lessen needle pain and anxiety. So what does that look like? It's breath work, distraction, applied muscle tension, cognitive behavioral therapy techniques, and we try to put it into an easy-to-use tool to help get people through the emotional journey of any blood draw or injection. And so the reason why I'm so excited about this is because we have the opportunity to impact every stakeholder. So patients and caregivers will have more of a sense of care, comfort, control. We healthcare professionals will be able to operate with more safety, efficiency, and confidence. Hospitals and clinics will see higher patient satisfaction scores, which now translates into higher reimbursements. Payers will actually save money because when patients are adhering better to preventative care and staying adherent to their treatment plans, this means fewer hospitalizations, saving billions of dollars. And finally, from a public health standpoint, we all stand to win. You know, there's so many opportunities where we can make an impact. So I like to bucket all of the needle procedures into 4 big categories. So we have preventative, which is all of the vaccines, diagnostic, which is all of the blood draws, treatment, which is huge. It's all of the injections that are happening in hospital, in clinics, in infusion centers, and increasingly at home. And finally, elective procedures like blood donations. So we at Thimble are setting a new standard of care. So the same way that you expect anesthesia before a surgery and pain management afterwards, you should expect Thimble or the like before, during, and after a shot. So we need everyone, each of you, to rally around the treatment of acute needle pain. I recognize that this is not an issue that's top of mind for most of us in healthcare, but I think it should be, because truly, what is the point of all these incredible advances in science and medicine when people don't want to use them? So let us all move the needle together. And so I'm not recommending, you know, just to bring it back, I'm not recommending that everyone drop it all and go start a business yourself and that's the answer. But really the point for me is I think it is worth reflecting on what your strengths are as an individual and what your perceived weaknesses are, because it may be that your weaknesses are actually your strengths. I mentioned at the beginning that I felt like, everything about me made me maybe not such a good doctor. And I ended up leaving clinical medicine for a few months to focus solely on the business. And it was an amazing period of real personal growth. And I missed seeing patients. And I'm so grateful that I was able to refine the love. And, I am in a beautiful practice with supportive people, and I've stopped beating myself up for taking too long with patients. I enjoy hearing about their lives. It helps me understand them better. And I'm not saying that my way of practicing is the right way either, because there are a lot of you that can effectively see 60 patients in a day, and I think that is amazing. And you're creating access for the millions of patients who need us. So keep doing what you're doing. My only point is I think that when we can finally be fully ourselves, we can really tap into our full potential and enjoy more fulfillment at work. So the takeaway is remember that there is no one who can build, solve, or heal like the real, authentic you. Your lived experience and gifts are unique. So go forth with authenticity and fearlessness. Thank you.
Oh, thank you, Manju. You absolutely made on time. I have one question, quick question. Where is this available, this needle? I mean, how is it available?
Yeah, that's a great question. So we are selling direct to consumer on our website, which is thimblehealth.com. We are also available for wholesale. And actually, what's really exciting is, my whole reason for this is like, how do we make a public health impact? How do we really, impact the rate of vaccine uptake and get people to adhere to their medications? And so I'm really proud that an international distributor reached out to us. And now it's going to be available to blood donation centers because we are currently in an emergency blood shortage. We are at the lowest rate of blood donations in the past 20 years. And when the American Red Cross looked into it, what are the reasons? Needle pain, needle fear. And so I feel so proud that we can offer something to help, replenish the supply. So there are many ways to get us. And so we're working on more ways where we can be distributed from the top down, because this, to me, is really something that should be provided by insurance companies and should be offered by hospitals, to empower patients. So that's the goal.
Thank you.
Thank you, Dr. Dawkins. Yeah, I just wanted to remind the audience that please feel free to type in your questions in the chat box. And while they're doing that, I have a question for you. How did you come up with this name, Thimble?
Oh, yes, that I wish I could take full credit. Actually, well, this points to the fact that we are surrounded by helpers all the time, and we may not see them, but they are there. And so when the idea started many years ago, actually my husband, who's my co-founder, his cousin is she at that point was a copywriter and a kind of, she's a creative maven. She's a designer, she's everything. And so she helped us build this whole, honestly, this whole company together. And she's the one who came up with the name Thimble. And what I love about it is it's simple, it's easy to remember, yes, but a thimble, represents, first of all, I'm not a sewer. I didn't know how to sew, but I always thought that the thimble was put on the finger to prevent being stuck by the needle. But then when I read a little bit more about it, it's actually also to advance the needle. And I think that really represents what our company is about. It is about advancing the needle so that more people can have access to the healthcare they need.
We do have a brief question and answer session. We have given 10 or 15 minutes, so.
I have a question. I'm a neonatal fellow. So my question to you is it possible to use this Thimble for any other procedures like lumbar puncture, spinal anesthesia while giving, because most of the time pregnant woman, when the anesthetist position them, it's difficult to get in one poke. Or even in neonatal or pediatric practice, doing a lumbar puncture is challenging, Is
Absolutely.
it possible? Yeah.
Absolutely. It can be used in all ages. I think the neonatal time, we have to be a little bit careful because the skin is more friable at that point, and there is adhesive. So, we haven't studied in that patient population. But I think if EMLA with Tegaderm is being used in the neonatal setting, then there shouldn't be any reason why our Prepare patch could not be used also. And that's the thing is, when we developed both of these patches, we tried to minimize any allergens, have the adhesion be as kind of painless as possible. So my hope is that it really can be used by everyone. But yes, another good question you asked is like, what indications, and there are no needle procedures other than the only one that I can come up with that it should not be used for. Well, actually, no, I have nothing. The only thing I can think of is the tuberculin test when you're trying to look for a reaction. I wouldn't use the post-procedure patch that suppresses inflammation afterwards because you won't see the true reaction.
So there's a question on the chat box, and this is from Nisha Nigel. Is it available in Canada?
That is a great question. It is not yet available in Canada. But I am strongly consider working on that. There is a little bit of regulatory hurdle that we would have to overcome, but I hope to soon. There's honestly been even more interest from Canada and Europe and Australia than even in the US. So I think we should go that route.
Okay. Kamar, any questions?
Questions? Okay, before I hand it back to Dr. Sheeja and Sindu, it has been my pleasure to oversee these, some parts of it. This one was great working with you two working women, Sheeja and Sindu, and back to you guys.
Thank you. I think there was one question about, I don't know if Shubha Anand is still on. There was a question about intermittent fasting, because it is so prevalent these days, people trying to lose weight with intermittent fasting, but I don't see Shubha on the line. Okay, so yeah, thank you all. I think I'll pass on the stage to our president, Sindu Pillai.
I just have one question. Is Dr. Oormila still around? Oormila, are you there? Is
Hear
Oormila-
me? Yeah, can you hear me?
Yes, yes. I just have a question for you. I'm just getting it in just a second.
Sure.
What practice pearls do you have for community physicians? That is an excellent session, by the way. Sorry about the timing. I know it's a vast topic that we cannot cover in 15 minutes.
Absolutely.
So sorry about that, Urmila. But
No, that's
what
okay.
what are your some suggestions, some ideas, and some advice, tips for us practicing community physicians
The
as
mo
far as menopause is
Yeah,
concerned?
83% of the women going through this suffer in silence. They have symptoms, but they don't say anything. Only 1/3 of them even dare ask or mention. So when we are caring for these women in this age group, we have to ask, what are your symptoms? And ask specifically, do you have symptoms of hot flash, symptoms of sexual dysfunction, dyspareunia, urinary tract infection, everything. And we have to seek this out and help them. And the earlier you treat, the better is the outcome. The later you do it, the more the complications. And screen for cardiovascular complications, use this as an opportunity for cancer screening, immunization, and also their social well-being. Antidepressants, all of it. If you're compassionate, then they will come forth. Very important.
Thank you so much, Dr.
Thank
Kovilam, and thank you everyone for today's all the attendees. Thank you for attending this session, and thank you to our wonderful speakers and moderators for doing a wonderful job here. Dr. Dawkins, Shubha Anand, Dr. Kovilam, and our keynote speaker, Dr. Jha, and Dr. Sheeja Pullarkat, and Kamar Amanullah. And thank you all your audience, all the audience, and for your participation and support. We will have our next Women's Forum session at the convention. That will be in August, 29th, 30th, and 31st. Most likely going to be on the second day, on the 30th of August. We will see you all there in Santiago at the Hilton Bayfront. Thank you again. Anything to add, Kamar, Sheeja?
No, thank you.
Thank you. Happy Women's Day to all.
Thank you. Same to all of you.